Hello and good afternoon. I know it's a post-lunch session for everybody, but it would be great if you could just give 10 minutes of your valuable time and we can talk about how AI-enabled digital solutions can help Uttarakhand as a state in policy making, in providing a better flow for the entire healthcare as well. I'm Dr. Devina Aswal. I'm the Associate Director of Medical Affairs at Tatvacare. Talking about Tatvacare, it's a company based out of Ahmedabad, and we are pioneering in digital solutions for all the health diseases, health conditions perhaps. And it's been 4-5 years now. We've been working in this area, and now we have started using AI and using AI-enabled tools for all our softwares. So I think we can have a short video play now so that everybody's introduced to the concept of what Tatvacare is built around.
Welcome to Tatvacare, a platform that bridges the existing gaps in our healthcare ecosystem through digitization. It is a digital system that empowers both healthcare professionals and individuals with chronic conditions to create positive health outcomes. It enables doctors digitizing their practice with Tattva Practice, an ABDM certified platform, and provides patients with personalized care programs delivered with My Tattva, a digital therapeutics application. For doctors, clinics, and hospitals, it takes care of OPD and IPD management, data security, one-click consultations, and comprehensive clinic analytics, highly customizable to all specialties. From prescriptions to case histories, lab reports, and past recommendations, healthcare professionals can now access all the information they need in minutes. And for the patients, outcome-focused goals, personalized care programs, and nudges by qualified health coaches to make lasting lifestyle changes. From maintaining vitals, incidents, and food logs to specially curated content helping patients understand the nuances of managing their condition. Tatvacare enables chronic patients to measurably improve their quality of life. Moreover, for healthcare professionals to stay ahead of the game, there is access to the latest clinical research, articles, practice-related and therapy-specific content. Lastly, for the pharma and insurance industry, Tatvacare provides intelligence, research, and chronic care services. In a nutshell, it covers the entire health journey by improving the quality of care on one end and enhancing the quality of life on the other. Tatvacare, the complete healthcare ecosystem.
Thank you for that. So I started my career just out of medical school, and I was posted in the exteriors of Dehradun in PHC Thano. That is where I started working from, and then simultaneously in CHC Raipur. So worked there for a couple of years, cut straight to RPG, and then post that the COVID pandemic hit. It was at the time of COVID pandemic that I realized that with the help of telemedicine platforms, the outreach to patients, to treat patients, the number of patients that you can see in a day has improved tremendously. And that just kind of, skewed interest into me. And I transformed and changed my portfolio entirely to AI-driven solutions. I've been working with Tatvacare now for digital health solutions for a very long time now. So let's see what I have to talk about today. I am really privileged and honored to be here in Uttarakhand with like-minded people. And let's start. The India's non-communicable diseases crisis. Nobody's unaware of it. And a lot of new associations are coming up, as in visceral fat development is coming up. Like before, it was only BMI dependent. Now we talk about visceral fat, we talk about other adiposity and anthropometric characteristics. It's an ever-evolving disease area. And now we can see that leading cause of NCD deaths are due to CVD, respiratory, diabetes, cancer. And the burden is still increasing. Most NCDs are very crucial to be treated early on in the disease because they have a very insidious nature. And patients present to the OPD only when it is too late and their disease becomes symptomatic. That gives us an opportunity, the opportunity of intervention, the opportunity of primordial, primordial effectivity. Why? Because there is a huge gap, as you can see here, from year 0 to year 10. We have the pre-disease, the metabolic change, and that started initially from a lifestyle risk. If we identify our potential risk factors here and identify the patients here, we can start giving interventions early on in the disease area. Uttarakhand has a very unique geography. We have dispersed hamlets, dark zones where there is no network coverage. Our resources in the field and the last mile approach, it's already thinned out, it's stretched. So what do we do about it now? The traditional model that treats diseases, and in focus, if we talk about the NCDs, they are very facility-centric, as in the patient has to go to the hospital to get any sorts of treatment, to get advice, right? We want to move from that traditional model to a more AI-enabled community-linked model, as in where the services reach to the patient, and we don't have to depend on the patient coming to the clinics or the PHCs and all the outreach areas in the public health programs. Because we all know that in Garhwal, various Garhwal regions and Kumaon regions, we don't measure the distance in kilometers, we measure it in hours. Itne ghante lagenge, yale gaon se wale gaon jaane mein. So this is how dynamics work in Uttarakhand. Talking about other changes that we propose as the future implementations, from reactive to a proactive approach. We don't wait for the patient to develop the entire symptoms of the disease and then act upon it. We try to be primordial in our approach, try to catch the disease, identify the risk factors, and start intervening at the point where the change is actually possible, not once the disease has already begun with its onset. Episodic care, we have to move from episodic care to a continuous care. A lot, many times, of course, in your practice experience, all the practicing clinicians here and the policymakers itself, once the patient of NCD goes back home, we don't know if the patient is going to revisit the facility again. We don't know how the patient is taking the medication. We don't know how their vitals are at home. We want to change that. We want to change that through a remote patient monitoring tools that we have integrated into our own systems. And we have been able to monitor patients better and get better clinical outcomes out of that. All this data that we get on our softwares, all the longitudinal data that we get on our softwares, we're sitting on a gold mine right now. And when we analyze this data, we identify certain patterns and certain insights that are critically very important on how to change therapy, on how to approach the patient in a more motivational way so that they stick on to their treatment plans. Right now, when the demand of a disease, if you have to take care of a disease and the demand increases tremendously over the time, the first thing that comes to our mind is to increase the workforce. What we propose here is a software-driven solution that keeps your workforce intact, less burdened, but more operationally successful. And of course, the fragmented data that we have everywhere in the system, we want all it to be brought in together, and then we do the predictive analysis on that. So when we did the gap analysis, we came up with certain factors and what solutions we can provide for such problems. For example, a difficult terrain. Maybe an A&M worker goes to an isolated hamlet, and she has taken a CBAC form. She maybe just, in person, she fills it on paper, and then maybe 2-3 days later, she goes back to the center, gives it to the A&M, she has it to the CHO, and then they upload it to the software system. We want it to have an offline-first approach so that everything is digitalized and everything is synced as soon as the network is approached in any of the terrain that they are moving in. The rising NCD burden, of course, we need more remote patient monitoring tools for that. Clinicians overload. This is not a new problem. It has always existed in public health systems everywhere, not just in Uttarakhand. We know that our doctors are overworked, They want to see more patients, but they really don't have the time for that. And counseling for specifically NCD patients is not possible in a normal OPD working hour. So we want it to, our system basically, to enable the doctors via our AI-enabled EHR, where their voice and the interaction with the patients are going to convert it into automated report forms. That saves time, and you don't have to type anything into your laptops and computers, and the AI just records it for you and gives you a report at the end of your communication with the patient. The patient does not feel that they just talk to a EHR computer system. So that's one thing. And referral breakdowns. We observed that follow-ups are there in our existing system, but we want the follow-ups to be bi-directional. Like in the sense when patient has taken a follow-up, we want to follow up the patient post that for second, third, fourth follow-up. Because NCD and all long-term diseases, they don't have an episodic mechanism that works for them. We want the patient to be in our follow-up care till a very, very long time, till the diseases are stabilized. We want to reduce the frontline burden by digitally enabling all our workforces. And of course, the data that is generated, we want everybody to know about how well we are doing. So we want it to get published. We want it to be research-enabled. And that's where the weak evidence loop will sit, because the RWE and DCT platforms that we provide will help you connect these two dots, from data to insights and to publication. The government already is much, much ahead. We just want to strengthen the already existing structure. We don't want to replace what's already there. We just want to propose as a team that let's work in collaboration and let's get this place into place and the workflow to kind of look much better, to have much better longitudinal data. So all the platforms that we have for NHM, ABDM, NP, NCD, and ABHWC, once we kind of collaborate, we will be able to, kind of provide a unified digital health strategy for that, because we are FHIR, guided and HL7 accredited, and for ASHAs and AMSM world, they will be forming the part of the main workforce lead in such programs. What data capability stack do we have at Tatvacare? We have the EHRs, we have the AI-enabled intelligence layer, we have the integration of interoperability layer through FHIR and HL7 standards, and of course the data management layer, the security and the governance layer, so that if you collaborate with the government or any other institute for that matter, the data is safe. We have the full DPDP Act clearance. How will it look in the future? So the frontline workers, through a digital CBAC app, can screen the patient, and that will be synced up to the system, go through the AI health engine, and it will be provided to the clinical care. And once the district level nodal officers or anybody in the policy decision makers, they can have a look at the dashboard and see how it goes, and then they can make policy decisions based on these analytics. What do we provide when we talk about IoT management? All the IoT or Internet of Things that we provide through our platform include the smartwatch monitoring, the CGM integration, the PPG-enabled vitals, the BIA analysis, and the BCA device. The BCA and BIA in particular are very important in monitoring the metabolic disorders, because they just don't take the waist circumference or the height or the BMI. We have integrated in such a way that you can get all the necessary anthropometric details of the patient, the visceral fat, the body hydration, the water hydration, the minerals, macronutrients, and even a metabolic age score that you can integrate as a part of any screening tool available and get more vital outputs out of it. And this tool can be used basically for mass screening for NCDs or any other disease. For clinicians, we have voice-enabled prescriptions, AI-generated clinical summaries, OPD and IPD digital workflows, ABDM-certified platforms. So what it does bring onto the ground. The documentation time is reduced 70%. The patient discharges 3 times more faster. And of course, it will be a paperless solution. When this kind of a software tool that is AI-enabled is integrated into public health programs, we see something of this kind of a flow, where right from community screening, we have the risk stratification, we have the facility assessment, the treatment management, and follow-up and reporting, which is very, very vital because it will have all the real-time program indicators. What it does for the patient. For the patient, it helps, once the patient is enrolled with one kind of ABHA-ID or any kind of specific NCD IAD also for that case, they don't have to, kind of introduce to, themselves again and again to different facilities that they want, that they visit for their disease per se. So once the ID has been enrolled, it stays in the system. Anything that happens given to the patient, it stays in the system, and it is visible right from the first treating doctor to the policy maker. This is what something it can look like. These are just prototypes that we have developed of what it can look like. As you can see, these are dashboards that give you a very clear picture of how the follow-up status looks like. So it's all color-coded and stratified. In that case, if anybody wants to have a look, they can see which areas they need to work on, which are the critical ones, right? This is for guiding CHOs and MOs for their protocol following. As you can see, you have a red flag check also there. So we can use a kind of module for this and develop it on machine learning. We can give it prompts and develop this entire tool for the government. And this is something that is very important. All our field workers have to undergo some part of training, even to fill the complete CBAC form that includes a lot of examinations, oral examinations, eye examinations. And we want our frontline workers to be well prepared for those things. So how will they do that? We propose a learning module so that they can stay updated with the kind of technique that they have to use at the work field level. This is what a dashboard might look like when all the data, the longitudinal data from all the patients from all the districts in Uttarakhand is going to feed into one dashboard. This is somewhat it's going to look like. You have the coverage for screening, the prevalence, the control rate, and treatment adherence. As you can see, they are marked in red and green just to show the improvement and where the government needs to focus and point and improve their workforce in. This is a dashboard that can show you the hot areas where you need more workforce, where you need more digital enablement. It can be customized in any which way. And this is the AI-enabled impact that we seek out of such data. 30% reduction in hospitalizations, 45% faster time to diagnosis, improvement in adherence, which is very, very important in cases of NCD, and of course, operational cost saving, because we don't have to hire new people in our workforce. We just optimize the entire workforce in such a fashion that they are AI-enabled now, and their workload is less, but what we want to derive out of it at terms of clinical outcomes, we are doing that. This is our research and innovation capability, like I mentioned before. If anybody wants to conduct a DCT, a decentralized clinical trial, Tatvacare is there for an end-to-end solution. So if you have the data, we have what you can do with the data, multiple options. And this is not all talk. For the last 3-4 years, we have been presenting our own data studies. We have our basically 3 programs which we started with in MyTatva, as MyTatva. The BREATHE program for COPD patients, the RESET program for NAFLD patients, and the GLIDE program for diabetes patients. These are all RCTs and RWEs that we have been showcasing in various international and national conferences like DTEC, INASL, NAPCON also. And these are our published articles where you can see we have plenty of evidence also that has been generated. One thing that I would like to highlight over here is this article. A novel digital health technology application derives score to assess lifestyle improvement in NAFLD patients. This was published in World Journal of Hepatology. Now, as many readers, Dr. Nahum Mendez Sanchez and his team, so this doctor was an EASL International Recognition Award recipient in 21. He happened to read our article, and his team researched on it, they got in touch with it, and they have written this letter to the World Journal of Hepatology editor, saying something like this, that the RESET program represents a scalable, globally relevant model for chronic liver disease management, highlighting the innovation and clinical value for this digital therapeutic approach. Now, what he is talking about is our structured plans which we give for the NAFL patient along with the standard of care. And that includes nutrition plans, that includes exercise plans and cognitive behavioral therapy, along with the integration of all the IoT devices. What were the key takeaways from this? Effective digital therapeutics plan. We had really impressive clinical outcomes from the studies. We had hit the target. All the patients reported reduction in 5 to 7% of their weight loss journey. The global model, he has in this entire article mentioned it to be considered as a part of therapy, new therapy that should be considered and taken into discussion in matters with EASL, IoT integrated, and behavioral change. Just wrapping up. So this was the last slide. Well, thank you all for listening, and it's a call for action from our end to Uttarakhand. Please visit our stall, we have it here, and we have multiple solutions for entire healthcare, and I think we'll have open a dialogue and discuss more on this. So thank you everybody for listening, and I'm really pleasured to be with like-minded people here. So thank you everybody.